All right. Well, hello, everyone. I'm Kristen Walton, optometrist in Omaha. So I'll get us started off with presentation today on ophthalmic imaging. So agenda today, just kind of overview of all the different imaging techniques that we have from the front of the eye all the way to the back of the eye, kind of going into some detail as to when we would use them, why we would use them, and just some little fun fact tidbits along the way. So starting off with photography, I'm sure everybody's familiar with slit lamp cameras, just having that right in the office or in the exam lane. So if you see something, you could quick snap a picture, super convenient as long as the technology wants to work for us. Sometimes offices have their own, like, if you go and do a Humphrey Visual Field or an OCT, they actually have a slit lamp camera kind of in that similar lane to take pictures. So you have a one spot to go to. For us, a lot of the times we're just doing a slit lamp adapter for an iPhone. And then that way it's super portable, super convenient for our patients to quick take picture, especially for those people that aren't super mobile. And then, of course, we're all familiar with fundus photography as well. So with external photography, usually we're documenting skin lesions or excess skin where the eyelid sits, globe position, infections, or growths. A lot of these things, some of them pictures can be used for insurance purposes if we're preparing for a procedure, or just monitoring as far as how treatment is going, if there's improvement, if there's worsening. So with eyelid skin dermatochalasis, if you're working closely to an oculoplastic specialist, they're going to be taking a lot of photographs of patients before and after surgery. Obviously, this gentleman definitely needs some eyelid revision there. All of that is excess skin, so if you just lifted that up, you'll be able to see his pupil again. He'll be able to regain functional vision. I'm sure he's probably somebody that's trying to use his frontalis muscle quite a bit, the very front muscle on the forehead, to try and lift his eyebrows and then his eyelids to see better. So blepharoplasty will definitely be helpful for him. This next case here, this eyelid ptosis, so obviously this is a little child. You can see that the skin on the eyelid's not necessarily the issue. It's where that eyelid is positioned. So it's more of a muscle related issue instead of, older age getting more redundant tissue there. So if you've heard of the MRD reflex, that's in relation to, I don't know if you guys can see my mouse on the screen or not, but the light reflex right in the center of the pupil, on the left-hand side here in that eye and their right eye, you can see the reflex is nice and centered. The lid is really tall and away from that reflex. If you go to the other eye, you can see that that eyelid's a lot closer. So measuring that difference is something that you'd see documented in an evaluation of, what do we want to do in this situation? Some things to note with that, in evaluations for oculoplastic surgery on how we want to intervene, phenylephrine can be helpful in deciding, okay, what all needs to be enhanced. Again, if the MRDs are pretty equal, we don't feel like there's any ptosis involved, we don't have to use the phenylephrine. But levator muscle and the Mueller muscle both have an effect on how that eyelid lifts on the eye. And the phenylephrine can stimulate that Mueller's muscle and see, okay, if we tighten that or adjust that, are we going to get enough lift, or do we need to do more to that levator muscle? So if you guys have dilated a patient before and noticed once you put phenylephrine in that their eyes look a little wider after dilation is set in and that they look a little whiter, that's that phenylephrine having an effect. Proptosis, that's when somebody's eye is coming forward, looking kind of bulging out of the socket. And so this can be common with thyroid eye disease if it's affecting the muscles and causing an inflammatory response there. If all blood work is normal for thyroid eye disease, there can be retrobulbar masses that can cause that eyelid to move, or the eye itself to move forward. And there's some tools in office where if it's very subtle, you can actually measure that and see, with treatment or surgery, is there an improvement? Is it worsening? Is it something we need to intervene with? This is a viral eye infection, molluscum contagiosum. It's more common in kids, can be spread via contact. A lot of the times this goes away on its own. Sometimes there's some therapy to kind of help the patients feel a little bit better. But usually time is on your side of having this resolve. Merkel cell carcinoma. Sorry to anybody that's a little squeamish with photos. It definitely isn't the prettiest thing to look at. But this is something that definitely needs to be intervened with quickly, and get to a surgeon where they can remove all of those cancer cells. Kind of some things to note with any potential cancerous lesions, lash loss, that can be a sign of some cancer cells moving in, just kind of some abnormal structure to the eyelid, where they have notches where the meibomian gland should be. You can see that coloring of the eyelid is not consistent. Margins are not well defined either. So all of those things are definitely red flags, and obviously a very large growth there. But when it's really subtle, all of those things can help decide if it needs to be biopsied or looked at a little closer. Moving into the anterior segment photography, we're looking at lashes, conjunctiva and sclera, cornea, iris, and lens. So here we have eyelash trichiasis. Obviously, this is a pretty severe case. Sometimes you can get trichiasis of just one or two lashes that cause a little bit of subtle irritation. But obviously, this patient has a lot more going on as far as overall health goes or underlying conditions. Probably some form of autoimmune going on where their upper eyelid is contracting on itself and causing those eyelashes to rub on that cornea. And we can tell it's been going on for quite some time because we've got a lot of blood vessels happening in the cornea, and that cornea looks pretty opacified. So probably just really worried about comfort and making sure that we don't have a large epi defect, worrying about infection at that point. Conjunctival cysts. A lot of times these are pretty small. They come from the lymphatic system of the eye. Sometimes you can lance them and drain them, but until you get rid of that tissue or where it's been enlarged with this cyst, a lot of times once you lance them, they'll heal themselves over, and then they'll just kind of repeatedly come back and be irritating to the patient. And especially something this large, lancing probably isn't going to do anything. This is going to be a procedure that's done in the OR to get rid of that area so it doesn't become a recurring problem. Corneal ulcers. This one with this ring effect is acanthamoeba. So documenting, when the patient comes in, what the status is initially before treatment, and sometimes differences in therapy and how the patient's feeling. Vision can be super subtle, so photographs can be very, very helpful with documenting the progress and confirming yay or nay, are we making strides in the right direction? More commonly that you'll see with bacterial or corneal ulcers is bacterial, fungal, those types of things. Sometimes they can be neurotrophic if the patient doesn't have any sensation or feeling left in their cornea. Iris colobomas. These are pretty rare. I've only seen a few, and they can actually affect any part of the eye. These are also known as like keyhole pupils, where the inferior nasal portion of the iris hasn't formed. It's a congenital defect. It's an incomplete closure of the optic fissure. I think it's usually like 5th week of gestation. But it can affect the iris, which can leave, and depending on how severe it is, some patients don't necessarily have any visual complaints. But some of them can be pretty light sensitive because the pupil's job is to limit the amount of light that's getting into the eye. So if we don't have that full closure, especially on the inferior portion of the iris, and we don't have the dilation effect and the constricting effect that a normal pupil would, bright light settings can be pretty challenging. We can have a coloboma of the lens and the zonules that support that lens. So then sometimes we can get dislocation of the lens, or we have to be a little bit more careful, or put more supporting structure in the eye when we perform cataract surgery. It can also affect the retina, leading to a little bit higher risk of retinal detachments, and then also the nerve too. And depending on the severity, that's where it can really impact their overall function and clarity of vision in that eye. And then lens dislocation, which I alluded to earlier, the front circle here, that's the pupil. Colored part is the iris. And then this edge right here, again, I'm sorry if you can't see my mouse pointer, but you can see the edge of the lens and all those little strands that kind of look like spider webs. Those are the lens zonules. So that's all of that support structure that keeps that lens centered in the eye. And if we have trauma, which is the #1 cause for lens dislocation, if we have any collagen conditions where it's a little bit, it's not as strong as it should be, then that can lead or predispose somebody to lens dislocation. So that's like Ehlers-Danlos syndrome or Marfan syndrome. Then we get into fundus photography, where we have color fundus photography, we have Optos wide field, and then we have fluorescein angiography. So color fundus photography, this focuses mainly on the posterior pole. So we're getting the optic nerve, we're getting the superior and inferior arcades, which are these main blood vessels that arc along that posterior pole. And then we have our macula here. So this photo is probably showing someone with a branch retinal vein occlusion. So we see the bleeding here along the veins, and then we have some edema stemming from that and some exudate as well. These are true color. Yeah. And then we go into wide field. So we get a lot broader view. We get out to almost the very edge of the retina. But you can see that we don't have as much detail as we do on the nerve. So if you're trying to take pictures to follow glaucoma and have a better idea of the starting point of what that nerve looks like, this isn't going to give you quite as much detail. Patients do really like this if they don't necessarily want to be dilated, but feel like they have a good comprehensive eye exam. So I think it's a good substitute. Dilation sometimes with that 3D view, we can catch some other things. Fluorescein angiography, if you're not in a retinal practice, you're probably not dealing with this a lot. The fluorescein dye is actually injected through an IV into the patient, and then it takes some time for that dye to circulate throughout the patient's vascular system, and then eventually making it into the eye. And then there's a serial line of photographs that are taken to see how that dye processes through all of the veins and the arteries in their eye to see, is there swelling, is there inflammation, is there overlying blood? So if we see this area, the nerve here, and then we've got our arcades, and then where it's super bright and hyperfluorescent, that dye is leaking there. So we've got some swelling. And then we can have some dye staining that's more central here, showing some inflammation. And then we can actually have dye blocking. So then we can have some overlying blood that's blocking any of that transmission there. Very similar to a CT scan with contrast. And then we're moving on to OCT. And ocular coherence tomography, that's shining light, infrared light towards the retina. It bounces off that retina from the tissue. And then that time difference is measured, and that's how that image is created. So we can see these beautiful pictures of all the layers in the retina. This, of course, is a macular OCT. We can see that little dip in the center is the fovea. So it shows all the different layers that are present. 10 different layers in the retina. The very bottom layer, we're looking at our RPE. And then we've got another hyperreflective layer, which is our photoreceptor layer. And then at the very top here and off to the side, you'll see it better in the next few images. That's the RNFL. And images presented like slices of loaves of bread. Yeah, just a lot of layers. You could think of it as like a cake. And that way, when we are able to image all of those separate layers, we can figure out, okay, where in the retina is this happening, figuring out what that diagnosis is specifically, and then how to treat it. Any questions so far? Doing okay there?
Yep, nothing, no questions in the chat
Great.
as of right now.
Perfect. Let me move my window here. So a little more detail on the macular OCT here. So at the very top, we have it labeled as the vitreous, so it's very dark in there. I don't know if you can see right below that vitreous label, there's a white line, very faint, but that's the posterior vitreous face. So when somebody has a PVD, or posterior vitreous detachment, that structure there, you can see that it comes and touches on the very front part of the retina. That has completely detached, and that's a normal aging process of the eye. Then we have the retina. And then underlying all of that, we have our choroid, which is vasculature there that helps nourish that retina. This is an example of an abnormal macular OCT. This is an example of macular edema. We have pockets of fluid within that retina. This could be CME, maybe they have diabetes that's undiagnosed or uncontrolled, looking at diabetic macular edema. This is an example of a macular hole. So instead of having that nice little dip in the center like we had earlier, I always compare it to like an upper lip. Now, for whatever reason, that has detached. And so this patient would see a black spot in their vision. Something on slit lamp, if you're trying to document a macular hole and maybe don't have a macular OCT, you can use a beam of light and hover over that area that you suspect to have a macular hole. And if it's a full thickness macular hole, the patient's actually going to see a break in that beam of light. And that can be a helpful diagnostic tool in how to refer that patient. Getting into the optic nerve OCT. So again, measuring the RNFL thickness on the retina. The green ring, that's where it performs the OCT, and then the image to the right is it laid out flat. RNFL layer on the OCT compares to age-based norms. So I know it sounds silly to talk about, but super, super important is one, name of the patient, so you can find it if you need to reference it later. And then their age, because for us to compare and figure out, okay, is this normal? They take all of this age-based data that they've collected and compare it, and that's how we can get these values. And then it just estimates if the nerve is thick or thin. Colors are great. They can be helpful, not necessarily an indicator of good or bad. So that's something that can be deceiving. We can actually have disease if patients are in the green, and that's why comparison over time can be very, very helpful. So the machine is measuring the RNFL thickness there. Then it plots it on this line as the black line. And then it's comparing to that age-based normative range, which is that green line here. And then it puts it all together nicely for us, looking at, okay, where are the areas that are a little bit thinner? Where do we need to look a little closer to figure out diagnostically what's happening? Okay. Humphrey visual field. And I know there was going to be a chat and training on visual fields and glaucoma. I'm not sure if that's happened or if that's coming down the pipeline, so won't spend too much time on this testing here. But typically test one eye at a time. Sometimes automated visual fields, patients will come in and need one for driving. And that's one of those times where a binocular visual field would be used. Patients focus on a central dot in the machine. Again, we're not testing central vision, so the eye shouldn't be moving. That's why we're focused on that central dot, and it's very important to reiterate that to the patient. And then the machine's going to show peripheral dots at varying intensities within their visual field. And we can focus very centrally, which is a 10-2. We can go to a 24-2, which is pretty common. If we want to get out to as many points as we can, then we're going to a 30-2. Patients click the button when they see the dot, and then the machine maps out what the patients can and cannot see. I think few points with these tests. I know it's not the most exciting test for the patient. It's not the most exciting test for the person that's administering the test. But being in the room with the patient and reiterating the fact that, hey, you need to keep focused on the central point, because if they're looking all over the place, the quality and reliability of that test, we're wasting their time and our time at that point if we're not going to collect good data. And then also reassuring those patients. Some patients coming in are either diagnosed with something for the first time, or they're being monitored for glaucoma for a long time. Some people can be very anxious and they want to do the best that they can because they know it matters on how they're going to be treated. Reiterating the point that if they miss one spot where this machine is testing, that the machine is going to repeat that spot a few times to make sure that that is a true defect or that they're truly missing that. Because obviously there's patient and human error in everything we do with this test. So then once that patient completes the test, then obviously we're going to get results. Biggest thing when you're looking at visual fields is you're going to have the right eye on the right side and the left eye on the left side. So our optic nerves are nasal, and so on the printouts, for each eye, they should be on that temporal side. So I know it's a little hard to tell, but it's kind of right on that horizontal line on both sides. But you should be seeing, when you lay the printouts out, what the patient is seeing.
Dr. Walton, there is a question now. The question reads, I work with multiple doctors and some like the fovea on for this test and others want it off. What do you prefer?
I think I typically prefer fovea on. Just getting as much feedback from the machine is what I would prefer. But it's definitely doctor preference. Just like when patients come in and maybe mid-exam, you decide you want to have a visual field, and some doctors prefer dilated versus undilated fields. Undilated is probably going to give you a little bit better estimate of what the patient's truly seeing. But for a baseline, I think I could go either way, undilated or dilated.
Thank you.
Yeah. Printout wise, testing details here, it's just telling you stimulus wise, what they're using, because there can be multiple variables with that. Background, that's pretty standard. Strategy, C to standard, C to fast, C to faster. Again, all depending, are you comparing from a previous test in one strategy? Are you doing a screening test? And then pupil diameter. Quality control, big one. Again, we talked about like setting up the patient, setting up those expectations. It's going to give us, okay, this visual field, is this reliable? Is this going to be repeatable? And if they're having a ton of fixation losses, that means we're not testing periphery anymore. We're probably testing more central vision. False positive errors, false negative errors. The false positives are what the machine, after they get a feel of what the patient can see, that they shouldn't be seeing that. That's maybe a patient that's a happy clicker or just clicking to get through the test. False negative errors is when somebody doesn't click the button when the machine thinks they should be clicking the button based on their previous responses. And so that's something that we have to pay attention to, because people can be falling asleep during the test because, again, they're in a dark room. It's not a super exciting test. So that's something that we have to keep in mind. Um, these initial numbers here is kind of the raw data points. The grayscale picture is really good for patient education, but we're paying attention more so on the fields on the bottom, or where you see all those little black squares to really know what the true defects are. The one on the left is the raw data compared with people of similar age. And then the other one's raw data normalized within itself. So that's the most sensitive to the true visual field defects, because sometimes people have dense cataracts or something else pathological going on. And that tries to thin all of that down to figure out, okay, what from the nerve are they actually seeing? Okay, and then we get into corneal topography and tomography. So corneal topography is just the mapping of the very front surface of the eyes. So there's a placido disc image here where it's just a bunch of rings that are shined onto the cornea. And then we get this reflection back of what those rings and the integrity of those rings look like. Corneal curvature bends the ring reflection. If we have any irregularities, then you're going to see it within those rings. It's going to capture that distortion, and then we get a nice color image to kind of represent what that topography looks like. So you can kind of think of it as a topographic map, and that's what I tell patients all the time. The warmer the colors, the steeper the cornea is. And it should be centrally, should be the steepest, and it should start to cool off as far as colors go towards the periphery as far as what a normal cornea would look like. We use Nidec scans for that corneal topography. And of course, it tells us a lot of other things aside from just what the irregularity of that cornea looks like. It tells us, kind of gives us an estimate of what that vision quality for the patient looks like, what those higher order aberrations are. And that just gives us an idea of what, if we're thinking cataract surgery, for instance, or if we're thinking other refractive surgeries, what the best technology or option would be for the patient to optimize their vision. And then we have corneal tomography. So the camera takes a cross-sectional photo. The camera spins to take many pictures, and then it reconstructs a 3D image. So instead of just having a topographic map of the front surface of the eye, now we're looking at the very front surface and the back surface to see how they're interacting, or if we have any corneal disease that's early in its stages, and we can pick up on that a little bit quicker. Comes into play a lot with people with keratoconus. Also, when we're considering any refractive surgery, just trying to do things as smoothly as possible. Okay. And Dr. Mai, you're more than welcome to take over, jump in whenever you want. It's up to you.
Hey everyone. Yeah, I can jump in real quick just because we are actually past half of the presentation already. So I can come in and finish it up here. Let me just share my screen.
Dr. Walton, if
Oh,
you want to stop share,
Oh,
and
yeah.
then Dr. Mai will share.
sorry for being a little late. Was in surgery, but thanks, Dr. Walton, for taking it on.
Yeah, no problem.
All right, so I think we were right here at tomography, and we talked about this kind of imaging. Name is a Scheimpflug kind of imaging, and what it does is that it takes it in cross-sectional slit, spins around just like Dr. Walton was saying, and then it constructs a 3D image here. And so this right here is that 3D image, and it makes this whole thing where it approximates and guess where the cornea is, the shape of the front, the shape of the back, where the lens is, and then from that, it gives you all the readouts. And that's a little bit of a more close look there. And so we actually have both of those machines here, the Nidec as well as the Pentacam, and it's pretty provider dependent as well as situation dependent on whether we're evaluating cataract surgery or for keratoconus, other corneal issues. for LASIK or PRK. But in general, a lot of the readouts do look something like this, where they are color coded. And so we can go right here. That first one here on this left side is just the curvature to the front of the eye. Green is usually pretty normal, and then red is where it gets steeper. And next, the bottom one here, that's how thick the cornea is. So green is pretty normal, then it gets thin to yellow, and then red is thinner. Then the next one over here is actually how far does the front of the eye come outwards compared to a normal eye? And so are there areas that are like a mountain, or is it pouching out more than normal? You can see here that that area is yellow, means it's coming out a little forward. And then this is the back of the eye. How far does the back of the eye, the back of the cornea pouch out more than a normal cornea does? And so again, the more it comes out, the redder and yellow it gets. And so if we put this all together, that area right here, the red, that's an area that's really steep. That area is very thin. This area is coming outwards from the front part of the cornea, and that area is coming outwards from the back of the cornea. And so in general, when we put this all together, that can be something like keratoconus here, where there's that thin area that's very steep. All that red part, see, it matches with this really steep area here, and it's pouching outwards. So that's basically how you would read some of these scans. Now it gets pretty complex, but as text just looking at this, you can generally see where there's red and green, and that's how we decide if there's pathology or not. Next is optical biometry. And so this generally is choosing or making measurements to help us choose lenses for cataract surgery or secondary IOL surgeries like a Yamani. And so these machines, they take measurements of the eye. They run these numbers through formulas that are already inside of the machine. So things you might have heard like the Barrett 2 formula, the Holiday formula, really old ones like SRKT. We don't really use that anymore. But these machines have these formulas. They run it through, and then they make a recommendation for what kind of IOLs we can use for cataract surgery or a secondary IOL surgery. And so this is a diagram of certain parameters that these machines will measure, like corneal thickness here for CT, the estimated lens position, which is this ELP, the anterior chamber depth from the back of the cornea to the top of the lens, how thick the lens is, that's the lens thickness, but most important of all is the axial length, the AL right here. And so this machine will take all of those measurements together, as well as the curvature of the front part of the eye, and then plug those into the formulas. Some of the biometers that we use here, we have the Lens Star. That's the one we most commonly use. The IOL Master, I don't think we have that at the main Sioux Falls area, but some other places might. This is the one that I'm familiar with when I used in my residency, but both of these are very common. And so the more traditional way in before we had these biometers was actually using ultrasound. So there are two types of ultrasound that we use. There's the A scan and the B scan. And so we'll go through them first. The A scan is this probe that shoots just a single beam, goes straight across, and it gives a readout here where there's these little spikes. These spikes means that the beam is hitting something and it comes back. And so the probe is able to measure when these beams are coming back. And so there's these big spikes here. And this was the first way of actually getting some of these measurements for cataract surgery. Looking at the axial length here, they would measure from that beam all the way to that beam here, and they would be able to take those measurements, put it in the formulas, some very old traditional formulas that we don't use much anymore. Sometimes we still do this if needed, if the patient has, let's say, a very, very dense cataract that the biometers can't get through, or in some certain situations where they can't, even sit up to get to the biometer. Sometimes an A scan would still be helpful. Or let's say we're doing mission work and we don't have an optical biometer, doing an A scan here would still get us some information that we can use. Now, the A scan doesn't only just get information for cataract surgery. These spikes also do tell us a lot of things about the eye too, such as how big the cataract is there like a retinal detachment? Maybe there'll be another spike beforehand here. And even in the back of the eye, let's say there's melanoma back there, some of these spikes will also take different shapes. And so an experienced ultrasonographer can actually use these patterns back here to tell what kind of pathology is in the back of the eye. So when you use that A scan, that single beam, and now you do multiple A scan beams and you put it all together, what we get instead of little spikes is we actually get a full image. Now, this full image is still just a flat image, and so you do need to pan the probe to get other cross sections, but it does look very similar to what you would use for seeing a baby or neonate, sorry. You can use the A scan to look at multiple things inside the eye, such as the cataract, the retina. This is the optic nerve, that shadow back here, and this empty area is the vitreous. A lot of times we'll use the B scan if we can't see into the eye, if the cataract's really thick, if there's a lot of blood, if there's corneal edema or corneal scar, and you need to see in the back of the eye and figure out what's going on back there. The B scan would help a lot with that. And so this is an example of a B scan here, looking at a choroidal melanoma. There's even what looks like possibly a detachment too in the back over here. And then lastly, we're going to move towards endothelial cell count. And so this machine takes a picture of the endothelium of the cornea. And so just a reminder, this is the cornea right here. Epithelium, then you have a couple layers of stroma in the middle, and the very back part's endothelium. It's a single layer of cells along with descemetous membrane, which is that orange layer right there. This is how it's supposed to look like normally, where you have these cells all smushed up against each other. They're kind of in a polygonal, hexagonal shape. And this layer here is responsible for pumping fluid out of the cornea to keep it nice and clear. In Fuchs dystrophy, that disease is when those cells aren't very healthy anymore. There's little patches of missing spots. And so this endothelial cell count actually is able to take pictures using specular microscopy of that area. They count the cells, looks at the cells shape, the number of them, how big they are, and then also missing areas. So say this is the healthy one on the left, and then this is an unhealthy one on the right, where there are patches of missing cells. And these patches of missing cells here actually correspond to what we call corneal guttata. Those are areas that are just punched out, no cells there. And then this is what's known as Fuchs dystrophy. So sometimes we'll get this scan just to confirm, or perhaps they don't actually have Fuchs dystrophy, but there are other things going on, just some corneal edema that we don't know what it's from. This scan is able to help us decide, is the endothelium intact? Is it healthy? Or is something else happening that's not coming from the endothelium? So that actually completes our section. There wasn't too much more imaging, so we can end a little early, but any questions there right now?
Yeah, there are a couple in the chat. The first one is, and maybe you can see them now that you don't have your screen shared, but what is your standard amount of cell loss before you recommend replacement?
Yep. And also there's what is a good normal amount of
Yes.
cells. So we'll actually start with the second one. It decreases as you get older. And so I think when we are younger, we even start out with about 4,000, and then it starts to decrease as we go on in our life down to 3,000, then to like 2,500 in like later adulthood. And then that's kind of about normal, even bordering the high 1,000s. Once we start getting to 500, that's actually when um, edema, corneal swelling starts to happen. So you can see that there's still a big amount of give there from, 2000 all the way down to 500. So we don't actually look at the number before we recommend replacement. Definitely, if we get to 500 for sure, we're thinking about replacing. But sometimes we're thinking about replacing a little bit earlier as a prophylactic too. And also visually, if we're looking at it and there's a lot of guttata there, many times we'll recommend replacement even before looking at the number. And then what would be a patient's symptoms with too low cells? And so when there's not a lot of cells in the endothelium, they can't work very well at pumping the fluid out of the eye. So the water in the aqueous humor will actually start going into the cornea, making it swell up, making it hazy. And so patients will just have blurry vision from the swelling.
Okay, well, maybe just another minute to see if anybody has any additional questions that you want to put into the chat. And if not, I'm just going to put the quiz link now into the chat. So if you want to use, oh, we do happen to have another question in the chat.
So Fuchs untreated can do a couple of things. Sometimes it might not actually do anything at all. Sometimes it actually continues to progress. And so it depends on how bad the Fuchs dystrophy of when we find the patient for the first time. If it's just mild, we would just leave it, see what happens. And then if it starts to cause problems, then we would treat it. Sometimes it's bad enough, we would recommend treatment right away. But to your question, it might cause edema or it might not. Sometimes we just wait and see. And then the last imaging thing that we didn't include in here is epi mapping. Some people do it, some people don't, but just a summary on what it does is that it measures the thickness of the epithelium. So instead of the endothelium that we were just talking about with Fuchs dystrophy, it is the layer on the very front part of the cornea, the epithelium. Think of it like the top layer of the skin there. And that gives us a couple of information about the rest of the cornea too. It's very important for LASIK, PRK, figuring out if a patient might have an underlying dystrophy, like a risk for keratoconus. And so it's very helpful to have that additional information to figure out, is a patient a LASIK candidate, or should they do PRK, or maybe nothing at all? Have some more questions here. Why does a plaquenil patient typically require a 30-2 visual field rather than a 24-2? So in general, it actually depends on the ethnicity of the patient too. 24-2 is great. The main one that we get for a plaquenil patient is actually a 10-2. And that's because the issues that happen for the vision loss is right in the middle of the macula, around the fovea, and the 10-2 is what typically will catch that. Asian ethnicity, those patients commonly will have defects from plaquenil outside of that area, way further out. And so they're the ones that we do recommend for a 30-2. But commonly, especially here in the Midwest, we would be doing a 10-2 for those. And the next one, common causes of conjunctival cyst. Actually, not really. We don't really know what they come from as long as there's no inciting factor like irritation or drops. A lot of times we just find them. It's just some kind of lymphatics in the area that don't drain very well. And so the lymph just backs up and causes a cyst. And then let's see, with the raw data from the visual field tests, what is a typical range for those numbers as they pop up while I perform the test? There are a lot of different numbers, so I'm not exactly sure which one this one might be referring to. So sorry, I can't quite answer the question is what I'm saying. I'm not really sure which numbers you're talking about for the raw data. I'm going back to look at the visual field printout. Maybe we can identify exactly which ones you're talking about here.
I'm curious if they're wondering about like fixation losses during the test. I mean, if there's any fixation losses, definitely want to try and, reiterate to the patient, but if there's more than 2 or 3, trying to restart that test to get better quality.
I think I might see what they're talking about if I can just share my screen again real quick here. So in the raw data, they might be talking about this area. Those are the raw values here that then point to this. So I'd say if you can see this area, that's all normal. And that's in the 20s, so mid 20s. And then as they drop down, 0 right there is when it starts getting black. So you got about mid 20s going down to some areas that are 7, 13, that corresponds to more gray area. So that's probably the raw data they might be referring to. But Dr. Wallen was talking about the fixation losses up here. That's where we see how much they look away. This whole area down here is also great to see how much their eye's moving. If it's a straight black line, they're not moving, but these spikes here show that they're kind of looking away from where they're supposed to. Any other questions there? Yeah, I was told that the positive negative areas is greater than 15. We should repeat the visual field test. Is this accurate? So negative errors are more allowed. They are taken a little bit better, versus the positive errors are things that we don't want to have very much. So yes, as a rule of thumb, if the positive errors is high, say like 15%, I think repeating the test is something that we can consider. Doesn't necessarily have to be that day. Sometimes it might not be just a good day for the patient. We can have them come back in a month or something and repeat the test. Negative errors, we can actually allow further on, even up to 20, sometimes 25. It's not that big of a deal. And so there's just that margin there where negative is okay and positive is more stringent. And then what component in Plaquenil causes toxicity? That is a great question that honestly, I kind of forget myself. Dr. Walton?
I don't have an answer off the top of my head for that question either.
Yeah, I don't quite remember. I know it affects the outer retina layer, kind of right around the RPE area, the retinal pigment epithelium, but by itself, I kind of forget. Well, I'm actually looking it up right now just to see. It looks like the actual drug binds to melanin in the RPE, the retinal pigment epithelium, and then that just the drug itself is just toxic to the layer of cells there. So it's not like there's a chain reaction or affects other things. The drug itself just seems to be toxic to those cells.
Well, this has been a really good education. Thank you so much to both of you for taking the time to educate us this week. I have put the quiz for those who are seeking credit in the chat and sent it out by email. As the emails are sent out to multiple people, sometimes they may end up in your spam. So please be on the lookout to your spam. If you haven't received something that you're looking for, let us know and we'll get it your way. Thanks again, doctors, and to everybody who attended today, and we will see you next Tuesday.
Thanks a lot, everyone.
Thank
Bye.
you.